Hello, everyone, and welcome. My name is Will Pearson, and I'm a fourth-year medical student here at the Medical College of Georgia. Today, I'll be presenting a case report of an acute embolic renal infarction of unknown etiology. So the patient in question is a 51-year-old male who initially developed some abdominal cramping while at a Japanese restaurant. Pain eventually evolved into 9 out of 10 left-sided flank pain with radiation to the testicles. And at that point, he sought care at the Aiken Regional Emergency Department. CT completed in the ED showed a 3 by 2 centimeter left lower pole hypodensity that was concerning for a segmental infarct. And at that time, he was transferred to the Augusta University Emergency Department. As far as past medical history is concerned, he had a remote history of paroxysmal AFib and was not on anticoagulation. He had squamous cell carcinoma of the right oropharynx back in 2017, at which time he underwent a TORS resection of the right tonsil, tongue base, and radical neck dissection, as well as adjuvant chemo and radiation. However, at his follow-up roughly 4 months prior to presentation, he had no evidence of recurrence. He also has a history of anxiety, depression, and insomnia, and is a former smoker with roughly a 20-pack year history. As far as medications, he was on citalopram and Dayvigo at the time of presentation. And on presentation to the Augusta University Emergency Department, his vitals were stable. He was afebrile. His pain was well controlled and dilaudid, and his physical exam was unremarkable. At that time, he was admitted and a urology consultation was obtained. He was started on a heparin drip and aspirin. On initial workup, his EKG showed normal sinus rhythm. His CMP was unremarkable with a creatinine of 1.0. CBC showed a white count of 11.2 and a hemoglobin of 13.9, both of which were stable. His urinalysis was clear, and a CTA of the abdomen and pelvis was obtained. Here we've got a video of the coronal of the CTA, and in which we can see the left lower pole hypodensity right in here. And then on the sagittal, again, from the CTA, we can see the left lower pole hypodensity here. And then finally on the axial, we can see the same lesion. So that impression from the CTA was a left lower pole renal infarct with preserved patency of the arterial branches supplying the kidney, as well as no identifiable source of embolism on the CTA of the abdomen and the pelvis. Vascular surgery and cardiology were consulted. A TTE showed no evidence of thrombus and normal cardiac function, although he was noted to have a moderate right to left shunt on a bubble study. Lower extremity ultrasound showed no evidence of a DVT. A TEE confirmed presence of the PFO. And as far as telemetry is concerned, he had no evidence of AFib while he was in the hospital. He was in the hospital for a total of 3 days and was discharged on apixaban, aspirin, and a statin with cardiology follow-up. They ultimately found no source of embolism, and the PFO was closed at a later date. So as far as conclusion for this patient, unfortunately, is a bit unclear as far as the etiology of his embolus. It could be due to his remote history of AFib, although his telemetry was normal. Could be due to a DVT with a crossing over through his PFO. Could be his history of cancer. It could be his significant smoking history. But unfortunately, there's no clear source of embolism in this patient. So with that, I'd like to say just a couple of words about renal infarcts in general. As far as etiology concerned, the vast majority are cardioembolic in nature, and this can be due to either atrial fibrillation, cardiomyopathy, endocarditis, or artificial valves. The second biggest category is idiopathic, which our patient would fall into. It could also be due to renal artery injury, and this can be due to dissection, trauma, Marfan syndrome, polyarteritis nodosa. And lastly, it can be due to any sort of hypocoagulable state leading to an embolus. As far as presentation, patients typically present with flank pain, abdominal pain, nausea, and vomiting. It can present very similar to a kidney stone or pyelonephritis, those sorts of things. Patients can have hematuria, and their creatinine can be elevated in cases of either large infarcts or if patients present with bilateral infarcts. And in the absence of elevated liver enzymes, an elevated LDH with this clinical presentation is actually highly suggestive of a renal infarct. As far as management / diagnosis, patients typically undergo a CT with contrast followed by a CTA to obtain better characterization of the vessels supplying the kidney. And those patients that present within 24 hours and have either complete or partial occlusion of the main renal artery or complete occlusion of one of the major segmental arteries, or if they present with arterial dissection, are candidates for either revascularization, percutaneous therapy, or surgery. And percutaneous endovascular therapy that can involve either thrombolysis, thrombectomy, angioplasty, or stent placement. And as far as medical management for these patients, they're typically started on anticoagulation and antiplatelet therapy and should undergo a source investigation, including an echo, EKG, and / cardiac monitoring for atrial fibrillation, and as well as a hypercoagulability to work up to see what the potential cause of the embolus causing the infarct was. So thank you. I hope you all enjoyed, and have a wonderful day.